Next, we have our third and final panel of the program, Obesity Treatment, Access, and Equity. Please welcome back Bob Cusack, along with Nancy Glick, Director of Food and Nutrition Policy at the National Consumer League, Dr. Jesse Ehrenfeld, President of the American Medical Association, and Dr. Bill Dietz, Director of the Redstone Global Center for Prevention and Wellness at the G.W. Milken Institute for Public Health. Welcome.
Thanks, Sarah. Nancy, let's start with you. Your group is putting together an obesity patient bill of rights. Tell us about that and how people with obesity really don't get the respect and attention they deserve.
Okay, do you all have like hours? Okay, so I am so grateful to be here. And of course, you heard Ramsey talk a little bit about
Yes.
this, our partner. So we basically came to this decision that America needs an obesity bill of rights because we asked a question, which is how come? How come obesity just keeps getting worse? And if you look back 20 years, a lot of the things that we're talking about today were known then, but Americans, I did the numbers, and if you count the number of people who have overweight and obesity, it's 73% of the adult population, which means that people like me are a minority in this country. And that's pretty depressing. So we started in 2021. We're part of a group called OCAN, the Obesity Care Advocacy Network. And a lot of people in this room are part of this because obesity is directly impacts cancer, heart disease, the whole group. So a lot of us are aligned and trying to solve this. And we partnered bringing together an expert panel. Mm-hmm. And we said, okay, so what's the state of obesity and why is it only getting worse? And what we learned is it's not because there isn't good science, there's amazing science. Things have changed. We now understand that this actually has something to do with brain signaling. So, and it's definitely not, let me put in capital letters, a problem of moral failure on the part of people who eat too much and just don't have discipline. Let us just decide today that we stop thinking that way. And that is a big challenge. So what we learned is not the science. And for years and years, there have been obesity treatment guidances. Bill, when he was in the government, was working on this. So there is a long history. Okay, so that's the good news. Mm-hmm. Okay, so why are people not getting care? Well, it turns out we call it the human obstacles. The first is this terrible outdated thinking, and some people today even were sort of discussing, let's just walk more. Let's buy a book and read about, calories. That's fine. And, I don't disagree with that. But at a certain point in time, people are beyond that. If you have significant amount of weight walking is great, but, I'm sorry, if you have 100 pounds, I think we need to do more than that. So there's that outdated thinking. Then there's this pervasive stigma. It is oppressive. And it is the health community, it's employers, it's insurers, and I would submit it's policymakers. So we have a lot of people who sort of consider people with obesity as less than. They did it to themselves. Why should we, worrying so much about this? Well, because we're all paying for it. And the next is that we don't have a healthcare workforce that's prepared at this point to treat most of the people with obesity because there's not training in medical schools. A lot of people, just basically don't know where to get the information. So we're sort of in a sort of a continuous loop here. And then there's the famous access issue, which is just astonishing. So, you heard Ramsey talk about the fact that Medicare does not cover these new obesity drugs because when Part D came into effect 20 years ago, there was a whole different situation regarding weight loss drugs. And so they were excluded as cosmetic. Well, times have changed. So we look at the healthcare system and we go, wow. From beginning to end, we have an issue. And I just want to pop off a few numbers to tell you why I'm so hot about this kind of thing. And so I'll just start with 1.72 trillion. That's 12 zeros. That's how much this country spends a year, and it's the economy writ large. So it's direct healthcare costs, indirect healthcare costs. It's lost productivity. It's disability. I mean, we were talking about, the massive costs for all healthcare. Well, consider 1.72 trillion of that is obesity. So next is 110 million people. Pretty big, huh? 42% of the adult population that has obesity. And again, that is like a record number. The next is 400,000. That's the number of people who die now prematurely from obesity every year. The same as cigarettes. Okay, so, we're losing people prematurely to a disease called obesity that most people don't understand is a disease. 230, the number of chronic diseases directly related to obesity: cancer, heart disease, hypertension, osteoarthritis. And then we get 10. I'm just going in reverse order. The percentage of Americans today actually have received medical care for obesity. Terrible. And then 2. That's the percentage of people who have been able to get access to these new anti-obesity drugs. The numbers, I don't have a lot of hair, but if I did, it'd be on fire. So we basically decided, as we're advocates, we're consumers. So we looked at this very differently. We went, well, wait a minute. If everybody else is sort of in this continuous loop, and we're having lots of meetings, we're having lots of discussions, and we can't break this system we're in, then maybe we have to break glass. Mm-hmm. And so we decided with the National Council on Aging that we were going to go directly to the public, and we're going to say to them, if you have diabetes, you go to a doctor, you get diagnosed, you get prescriptions, you get seen. Well, suppose you have the disease of obesity. Mm-hmm. Why can't that happen for you? And so we want to empower people to ask questions, to demand to be treated, and we want to sort of change the dynamics so that basically, as somebody said, we become the people in charge.
Right.
And my fiance, wonderful man, is a ordained Presbyterian minister. So I've started to think biblically now. And I decided, I just had this brainstorm, I don't know, I didn't have enough breakfast, about Martin Luther putting, 500, points on a church wall and starting the Protestant Reformation. So I want our Obesity Bill of Rights to do that.
Okay. Jesse, let me bring you in here. Tell us about the physician perspective on treating obesity and how doctors are pushing for insurers to cover obesity treatments.
Sure. So thanks for having me. This is an important discussion. And the AMA recognizes obesity as a disease state. And that's a really important starting point when we think about treatment, access, and frankly, the stigma that is preventing people from getting the care that they need, that Nancy has described. You know, 1 in 5 kids struggle with obesity. 1 in 3 adults struggle with obesity. We can only start to reverse this tide if we treat obesity as a disease and we make sure that people have access to all of the therapies, treatments, interventions, and strategies that take a whole variety of approaches, including obviously the new medications that are coming online. So we worry about carve-outs for particular treatments that we know have evidence behind them. We worry about access to treatment for obesity writ large. And as we think about making sure that we can elevate the health of the nation, those are obviously priorities for the AMA.
Bill, just regarding new drugs and treatments on obesity, and there's been a lot of headlines on that, and that's great. But how do we tackle obesity in a comprehensive, long-term fashion?
Well, the first thing to say is that we're not going to be able to treat our way out of this disease.
A lot of people think that now.
Right,
though.
that's right. And these medications are enormously promising.
Right.
That we now have medications that have that reduce obesity and by 5% of body weight in 85 to 95% of the population. And the most recent drug, tirzepatide, accounts for 20% weight loss in over 50% of the people who consume that medication. So that's great. But I worry about
But
a couple.
it's not 100%.
No,
right?
it's not 100%. Well, but it's getting closer to
Okay.
surgery. And that's the important point to make. There are limitations to these drugs. That expense is a major one. That the semaglutide, Ozempic, costs $1,300 a month. The tirzepatide is about $1,000 per month. Ozempic is about $800 per month. So these are extraordinarily expensive medications, particularly since long-term adherence to these medications is going to be required.
Do you think that will go down a lot over time, or no?
I think that that Lilly's tirzepatide is already competing with semaglutide, which is the Novo product. But that said, there are lots of barriers around care. Jesse mentioned one of them, and that is physician training. And my biggest worry is that the kind of counseling which Nancy described, which dismisses obesity as a personal failing, in which providers say you just need to move more and eat better, that's now going to be replaced by take this medication and everything will be hunky-dory. And that ignores the fact that primary care don't know how to treat obesity, and that the medication alone is not going to be sufficient, that it has to be surrounded by other behavioral reinforcements, so that we know that when the medication, when this plateau in weight loss occurs in response to the medication, that we need to sustain that with strategies other than continuing the medication, because that's going to be enormously expensive. It's a lifelong kind of problem. And I think in that context, the focus on behavioral change, intensive behavioral therapy, has been lost. And we know that that's a very effective kind of strategy. And the best illustration of that is that the most recent trial of tirzepatide, SURMOUNT-3, selected patients for that drug based on 12 weeks of behavioral change. And those individuals who enrolled in the trial had to lose 5% of their body weight. If you look at the curves of their weight loss, the slope is indistinguishable from that of tirzepatide, emphasizing the importance of this kind of intervention. Now, all that is said around treatment, but as I said at the outset, we're not going to be able to treat our way out of this. And my hope is that that recognition and the expense and the kind of prevalence of treatment that we're going to lose our focus and the need to focus on environmental strategies. So one way of thinking about this is that the medications have a internal effect, that they sensitize the individual to satiety, to a sense of fullness on the gut-brain axis. But we also need to think about the ambient environment, the external environment, because that's what's driving this pandemic. And I think we know some of those strategies for younger children, like WIC and like the universal school feeding. But we don't have in place the kinds of other strategies that are going to be necessary to transform the behavioral environment around nutrition and physical activity.
I couldn't agree more with that. We have to treat this as a public health problem, right? And there's so much attention on the new medications, and that's an important component, right? We need to make sure that we have access to therapy that has evidence behind it, but we also have to take a public health approach, right? To make sure that the SNAP program is configured in a way that we have access to foods that are healthy, nutritious. So we have education in schools so that kids in grade school learn how to make appropriate choices, so that we have places where people can actually go out for those walks and be safe and not be afraidful that they're going to be harmed when they're trying to get exercise. So those are all important sort of upstream drivers that we know can improve health, that are as important as the access to treatment when people have challenges with obesity.
And this is just a follow-up question on the challenges physicians face other than insurers. They face a lot of challenges. You have patients who see commercials and they ask their doctor about certain treatments. Yeah. How is that? I mean, we're going to see more of that, obviously.
We're already seeing some unscrupulous business practices, and I will tell you, it reminds me of about 10 years ago. I drive down I-65 in Nashville, where you still live, and I'd see the low T billboards.
Right.
Those have kind of gone away, but we're now seeing, online advertisements for compounding pharmacies that purportedly provide this medication. Well, this medication you can't get from a compounding pharmacy because the active ingredients are obviously proprietary, and there's a licensing agreement. So those things, I think, are going to harm patients, and we're very concerned about that. We want to make sure that that doesn't actually lead to challenges as this market is evolving.
So you're seeing a lot of people paying a lot of money for something that doesn't work.
That's a concern.
Yeah.
Well, there's this whole magic bullet
Yep.
aspect to obesity, which has been around for a very long time. Fen, et cetera.
Yep.
And then there's this diet and grapefruit diet and all of that kind of stuff. And I agree with the gentleman here about this being a public health issue, but it is, we have to, I think, start by, again, empowering people to think about the whole concept of obesity differently. So the people who, a lot of them, these stars, et cetera, the Ozempic effect, et cetera, there's some very wealthy people who will always be able, because price isn't an issue, and they get a lot of attention for this. But the majority of the people today, are not thinking like that. And they're stuck in this feeling that, I'm a failure. I don't know what to do. They confront a situation where they have a hostile environment in terms of the fact that, physicians, nurses, et cetera, again, have this great bias. And so from our standpoint, I think it's a system-wide, which starts with prevention. Our Bill of Rights doesn't focus on that, because we sort of deal with you at the point where, you are, quote, a patient.
Right.
And those issues are critical. It would be fantastic if we could do more there. But ultimately, I think we all need to work together to change the mindset of everyone about what we're talking about here. We're not talking about getting into a smaller, a dress size. And that still goes on. Mm-hmm. And we need, to have doctors who don't see this as I can make some extra bucks, but that this patient of mine has a disease, and he or she probably has comorbidities as well. all these other things that you probably come into your physician with diabetes and you need to have help reducing your weight. So I think it's very important for us to sort of realize that this whole challenge of obesity, it is a hairy, big issue that, we have to confront, from education and, just working across the system to address it. And I would say, for example, employers who think that they're solving the problem by giving you a gym membership are not really helping you that much.
Right.
So we have to do a lot more than that.
Well, Bill, I want to pick up on that societal thing. And I've noticed over the last week in preparing for this event, you don't see many commercials on asparagus or on spinach. You see it on fast food. You see it on cheap food. Now, you can't legislate that necessarily, but that's a big impact. And obviously that's one of the reasons why obesity disproportionately affects minority populations.
Yeah. No, I'm glad you raised the minority populations because the disparities with respect to obesity are significant and socially determined. They're not genetic.
Right.
But we do see a higher prevalence in blacks and in Mexican Americans or Hispanics. And that does not have a genetic cause. That's a direct consequence, I think, of racism, of structural racism. And I think DC is a prime example of that with only 3 grocery stores across the river.
Right.
And that means that these populations rely on corner stores for their food, many of them. And that food is ultra-processed food. This is one of the, I think, current foci of research. And increasingly, we recognize that ultra-processed foods, which contain very little real food, are an important driver of obesity and mortality. The reason for that is that they're high in fat, salt, and sugar, and they're delicious, and they're inexpensive, and they're widely available.
And they're addicting.
And they're addictive, and they have a long shelf life.
Yep.
So what's not to like about it? Well, this comes back to why isn't there better produce in those stores? Well, that's expensive, and the distribution network is limited. So I think that poses a real important challenge that we have to address if we're going to really resolve this problem.
Jesse, your thoughts on that?
Well, there are clearly policy options and opportunities to change the market, right? To make the nutritious things that can keep people healthy less expensive and more accessible, to eliminate those food deserts. There's a tremendous surge in interest in food as medicine programs, which can be highly effective. And in fact, in my day job in Wisconsin, I funded a bunch of those things because we've seen dramatic changes in terms of people's overall health, diabetes control, hypertension, challenges with high-risk pregnancy being tremendously impacted through the availability of appropriate nutritious food. So again, you have to take a public health approach. We have to make sure that the complexities around cost as a barrier, ethical questions about who gets access to what treatments and therapies don't overshadow some of the foundational work that we still need to do from a public health perspective to prevent obesity.
Let me just throw out body mass index. Is that a good thing or a bad thing?
Oh, it's a little controversial, and I'm sure Bill can talk about this as well. It's a screening tool.
Yes.
And, everybody who goes in for their physical gets on a scale. Mm-hmm. And not everybody has a conversation about it, mm-hmm. but that information is available. And I think from our perspective, if discussed properly, it does allow for a conversation about whether or not one should learn, what to do or may need treatment. But it is, it's crude in terms of the fact that there are challenges. Bill,
imperfect is probably the right word. And look, it was generated based on people that look like us on this stage, right? Non-Hispanic white people historically drove the normalization tables for BMI. So the AMA says that it's imperfect. it should be used in conjunction with other measures. And I spent 10 years in the Navy. The DoD has figured this out because, they use BMI. And then it turns out we have a lot of very fit, healthy sailers.
Yeah, athletes, right?
That had a 30-inch neck.
Right.
And so, there are other ways to do body composition assessment that just make sense.
Bill?
Well, I think it's critical to recognize that the BMI is a screening tool, as Nancy said. And the origin of that tool is based on white populations. But all that said, there's very little variation across ethnicities in terms of the utility of a BMI, meaning that if you're a child with a BMI over the 95th percentile, the excess weight is fat. If you're an adult with a BMI over 30, the excess weight is almost always fat. There are these exceptions. The NFL, most notably, and some of your sailors. But I think that it misses a lot of people who don't have a BMI of 30, or a child that doesn't have a BMI of the 95th percentile, who has excess body fat and an unhealthy distribution. That's the other thing, is that the distribution of body fat has a noted impact on morbidity and mortality. Central obesity, visceral obesity in the abdominal compartment is a really risk factor for significant comorbidities, because body fat is not just this repository of fat. It releases all sorts of inflammatory proteins, which is another driver of the consequences of obesity.
What would be your advice as we wind down in time of people watching this who have the disease, who have obesity? What should they do? Where should they go for help? Anyone?
I think the challenge is finding a provider who knows what they're doing.
Okay.
As Nancy said, obesity is a heavily stigmatized condition.
Yes.
On the level of race. And that means that providers come into this, and providers are one of the most, the group that stigmatizes people the most. And most people with obesity have had a bad experience with their medical provider, which means they avoid care. And that in turn predisposes them to lack of screening for breast or cervical cancer, for example. So the first step is to find somebody competent and who will listen and who understands the disease of obesity. Part of that falls on us to train those providers. Most medical schools don't have a course on obesity, don't teach students about obesity, don't teach them the language to use to talk about people with obesity as opposed to obese people. So it starts with us, but that patient, I think, needs to find a provider and a provider that is familiar and understands how to use these medications, and that the medications are not the only solution, that has to be surrounded by environmental changes.
Jesse?
A piece of this relates back to that education piece. The AMA has made a major investment, nearly $50 million, in our nation's medical schools and training programs around our Accelerating Change in Medical Education program to try to spur innovations like making sure that our upcoming generation of students and trainees understand how to appropriately treat patients, how to reduce that stigma. We always tell people, talk to your doctor. And I will say that there is something very powerful when a patient is empowered to seek the help that they want.
Nancy, got a minute left?
Yeah.
Closing thoughts.
So I would say we are going to be launching our Bill of Rights, and we are going to start a campaign, a national campaign called The Right to Obesity Care. And we hope that we can get enough attention, again, to at least start educate people and make them feel better about themselves. And our Bill of Rights is aspirational because we know that a number of things we want to have done, for example, for people to be able to ask their doc whether or not he or she is trained in obesity and not have a bad result from that, is to build this workforce, and we thank you very much for that. But I think right now we need good information, credible, respected. Julie Guberning talked about this whole idea of this trusted discussion. Well, the first thing I think we could do, we could all agree, and I know you were working on this, but I think we absolutely say that starting now, that we do not allow people to be disrespected. That if you go into a physician and she fat shames you, that we should not tolerate that. We really shouldn't. And I don't know what kind of mechanisms are necessary for that, but we could stop that. Mm-hmm. We could stop that now. And that would do a lot right now to start changing the dynamic.
Well, we've run out of time. Please thank our great panel for an important issue on obesity. Thanks so much.